Welcome to CareTalk, America's home for incisive debate on healthcare, politics, and business. I'm John Driscoll, the chairman of UConn, and this morning I have the good fortune to be exploring the great new company OnMed with the CEO, Karthik Ganesh. Karthik, welcome to CareTalk.
Thank you, John. Glad to be here.
So, Karthik, our listeners would love to know a little bit about your background and, how you came to healthcare and what got you interested in solving the problems that your company solves. But maybe tell us a little bit about where you're from and how you got to healthcare.
Of course, 25 plus years in healthcare. And I'd like to think I've touched this from all the angles it can be touched from. I've done consulting, healthcare consulting with both EY and Deloitte. I've done big payer with Aetna. I have run a PBM. I've run a provider-sponsored health plan. Helped build a value-based and ACO backbone, if you will, ground up. Helped Cigna launch Care Allies, which Cigna recently transacted. Ran a value-based PBM, and then now running a healthcare access company.
And how did you get into this? What drew you to healthcare in the first place?
I'm gonna probably say happenstance. I was Ernst & Young. This is when EY Consulting was the largest healthcare practice in the country, and GE Healthcare was my first client. Express Scripts was a fast follower to that, and just never looked back. I don't believe in coincidences. I felt every step along the way. I felt both a passion for the industry as well as a strong belief that in my own way, I've been contributing to make one small little difference in the broader healthcare continuum. But for all of that, I have never felt the perfect alignment of work and soul as I feel at OnMed right now. I have been access has been incredibly important to me. It has been those, the folks who've known me for, 10, 15, 20 years have known that, I've been a very, very vocal advocate of access. I have over the years, even as you think about health plans and the belief that, you've got to squeeze your network to be able to get the most out of it. Always had a very visceral.
Just to kind of break that down for our listeners, having been a health plan executive as well, the simplest way to reduce cost is reduce access in some ways.
And I've always had a visceral reaction to that.
You will get greater discounts from providers if you can concentrate. But it also means a trade-off, as Karthik's pointing out, of access, because we live in a system where some of the most vulnerable and most chronically ill patients have real challenges to getting the health care they need. Karthik, you've jumped around through a lot of different parts of healthcare. What drew that curiosity to take on a new challenge? Because certainly most people in healthcare will stay in consulting, stay in health plans. Our tribes tend to be very siloed in healthcare. No, is there any through line there?
I would say the through line for me is I grew up in India as a military kid. I'm very comfortable with change. Any level of continuity, quite frankly, makes me more uncomfortable than comfortable, and which is a little counterintuitive. But I will also say, John, the fact that I have moved around healthcare as much as I have is something that I would arguably look at as my secret sauce. One of the things that I feel...
It's a perspective advantage for sure, because most people live in those silos of a PBM or pharmacy
or plans. You're exactly
health
right.
plan or ACO, or the people in provider-sponsored health plans. Those are the ones that hospitals and doctors own. Typically stay there. Healthcare is a career where often, it's a pie eating contest where as you rise, it's a bigger pie and you've got a little bit less time to eat it. So maybe talk a little bit about OnMed's really, I think, a breakthrough idea, at least in the way I think about it. But maybe how did you come to the idea, and maybe tell a little bit the origin story of OnMed? It's not just about access; it's finding a solution.
Is finding a solution. And OnMed has been around for about 8 years. I joined OnMed about 17 months ago, 16 months ago. The idea was a brilliant one. When we look at the two modalities of care that exist today, the only two that we are comfortable with or are aware of are one, the traditional brick and mortar clinic based setting, or at the other end of the spectrum, as we went through COVID, we got very comfortable with telemedicine. And that was the other end of the spectrum. Both have hit a very natural ceiling. And I would say more unfortunate than fortunate. Brick and mortar, we're running out of clinicians as a country. It's incredibly expensive to stand up. 2 million plus about 750K a year to administer, but to operate. But even if money wasn't a barrier, we're running out of clinicians as a country.
We don't create enough doctors.
We don't create. We needed 200,000 more 4 years ago. We're producing 17,000 a year. And there's a huge chunk of the folks who are in practice today who are either pre-retirees, or just burnt out coming out of COVID. So then we go through COVID, and then we think telemedicine is the silver bullet. But it's been around for 18 years, and the warts that existed still continue to permeate telemedicine. When you've got a clinical conversation that lacks vitals, scans, diagnostics, it doesn't feel like a clinical experience. And as a result of that, we have continued to see the adoption of telemedicine drop year over year. And it now has settled into a place that is fairly consistent with digital health tools at large, which is in the 5 to 7% adoption range, which, given the fact that the demand for access continues to grow as we get, to almost be provocative, I've always the why in my mind in terms of the demand for access growing is the fact that 11,000 people aging into Medicare every single day. According to the WHO, right, we know 3 out of 4 Americans are either overweight or obese. Medicaid enrollment has grown by 33% over the last 5 years. So to put it very bluntly, we're getting older, heavier, and poorer as a country. And close to 31% of all US adults have multiple chronic conditions. So we're also getting sicker as a part of that. The risk pool continues to get just more and more tainted in terms of gets deeper and broader, and it's growing demand for access even more. And the only two ways we have historically looked at access have both hit a natural ceiling, as I called out. You can't throw the baby out with the bathwater, and that's where OnMed comes in. Think of it as a clinic in a box. It's an 8x10 care station that brings the best of your traditional, the comprehensiveness, the comfort, the confidence that you get with a clinic, married with the rapid scalability of telemedicine. You've got an 8x11, care station, call it a kiosk. You walk into it, roll into it based on what your situation is. The bulk of the floor is your weighing scale, which if you're in a wheelchair, it handles that comfortably as well. 65-inch screen in front of you. The technology is not overwhelming. We're rolling this out in West Alabama, West Texas, parts of the country where technology is not a friend. The person walks in, they press start, and they go.
Yeah, just describe that experience. It's effectively you're taking a lot of what the techs or the machines in a doctor's office would do, upgrading them to modern technology and rolling that out so that effectively you're getting the data and the content that is really what the doctors and clinicians, PAs, nurse practitioners are using to then diagnose and treat, and making it pretty accessible. I mean, that isn't a big footprint. I mean,
that is not a big footprint.
And so you're sort of substituting the need for a clinician in a brick and mortar, or even an urgent center with the center. And then what happens to that? How does first, from a patient perspective, how would I find out about this? Is this like a part of an urgent center, or is it part of a clinical practice or a doctor's practice? Like
We have
now that we've described this sort of Star Wars equivalent of access to evaluation, how do people come to
How do people come to get to
roll
it?
in?
We have we clearly need to do more from a B2C marketing standpoint, John. But what differentiates the Care Station as compared to anyone else who has tried kiosks in the past is the fact that this is a B2B play. And we talked about my secret sauce, if you will, being the fact that I've touched healthcare from so many different angles. There are a number of truths that I firmly believe hold true irrespective of where we are in the healthcare spectrum. One, B2C as a pure play has never worked. And it doesn't matter if you are the Uniteds of the world with all of the money that they have to have in their treasure chest.
Everything that would be, well, United, all the money in the world clearly is not focused on the consumer. But I'm just saying, I think just to break it down, most other digital businesses have succeeded by going direct to consumer. There have been a lot of attempts, both in service offerings or products. The only thing that's really done well is telemedicine for drugs, which turned into a scam, during COVID. Where that and I think it's now adapting to online pharmacy is, I think, starting to break through a little, Karthik, but that's the only one.
But I'm gonna challenge that a little bit, John, and say that even as you look at digital solutions from a B2C standpoint, over 95% of them are not profitable. And at the end of the day, if you're running a business, I mean, I've always believed this, if you don't have a clear line of sight to profitability, you're an experiment, you're not a business. You have to know what it takes to get profitable. That's the entire idea of running a for-profit business. B2C has been challenging in healthcare. That's one. Two, tech for tech's sake has been a challenge in healthcare.
It certainly has.
The American consumer and the American patient see things very differently, and we may be the exact same person. We are not comfortable. We may be comfortable with tech in every other aspect of our lives, but we like the human interaction as it pertains to healthcare. And we have been, go ahead.
And so as you think about that, you've solved the solution of building a massive hospital or clinic. How do you bring in that human interaction to the sort of
this little care station,
all of the diagnostics that you're making available?
And that's been very important to us, John. So we have made sure that the technology inside of the care station is not overt. It is you walk in the 65-inch screen, you don't have to do anything more than press start. The clinician shows up and takes you on the journey. This is a live clinician. This is not an avatar. This is not a bot. This is none of that.
It's not the metaverse.
It's not the metaverse.
With no legs.
This is a 65-inch person on the screen. So you basically feel the person's in the room with you at that point in time. And she's taking you on this journey. And, even she gathers your information, even your consent forms. She takes you through all of it, and you've got a sign at the end of it. And it's been fascinating as a journey for us, even, really humanizing the tech. We had 4th grade level consent forms. We took them into West Alabama, portions of West Alabama where they couldn't handle the 4th grade level consent forms. So we had to make them 3rd grade level consent forms.
Yeah, and it's not, again, this isn't a dig on any part of the country, but when I was building materials for Oxford Health Plans in the 90s, we brought in elementary school teachers to rewrite all of our literature because most of the literature is written for lawyers, accountants, and actuaries, not for actual consumers who come to healthcare vulnerable and scared, let alone forget their academic level. You want to make it simple so that you don't create a barrier.
And that's health equity in a nutshell. What you just called out, John, in my mind is health equity in a nutshell. How do you make healthcare more intuitive and more accessible for the underserved, where things that we take for granted, like technology, is not a friend? And, this is the part of the country that doesn't live in our world of wearables and AI and bots and things to that effect. This is the part of the country.
Don't tell CMS they're betting long on the whoops and the wearables, and there is something there.
There's a place for that.
There's a place for that for sure, and I'm excited about that. But I think what you're solving for is the access to diagnostics for the vulnerable, which I think is super interesting. How do you maybe talk through how, who buys this, and how does a consumer in parts of the country get access to it? Is
Access to
it their employer that would buy it?
It's a combination, John. So we have payers who are doing this. So we've got national contracts with United, Molina, etc. They're doing this for a bunch of different reasons. One, it is a more appropriate site of care from an ER standpoint. So that's
But
one.
it's effectively giving, for a lot of people who access emergency room care for
An
basic primary
alternative.
care, and when they access that emergency room care, it's actually very expensive because it's a terrible consumer experience if you're not if you're not triaged as super urgent, and
Exactly.
but it is where absent the endless wait on the phone call and the regular doctor's hours, where a lot of America will access primary care. So that's an
That's right.
economic win
It's an
for the
economic
health
win for
plans,
the payer and for the
and
provider as a
and
part of
and
that as
and, and
well.
it creates access, probably safer access for a lot of patients.
75% of the people who go to the ER are for non-emergent reasons, right? So this provides an alternate venue for them. It also creates additional access for payers in the communities they're getting into. So our clients are payers. We've got a bunch of health systems in the mix as well as a part of this. It's the same win for them, including getting their brand out into their catchment areas so folks can access it in rural communities, etc. Um, we've got universities as clients. So South Carolina State, Tuskegee.
But
Um,
it's all about expanding access
it's
to
about
to
expanding
primary
access.
primary and chronic care for non-emergent
I would say
situations.
primary, urgent, and some post-acute. What we also continue to find, John, is that underserved is not a rural America challenge. Underserved, quite frankly, doesn't differentiate based on your net worth. You could have, John, I tell people this all the time. I live in Greenwich, the hedge fund capital of the country. 80% of the community can't, it doesn't matter what their net worth is, they 80-90% can't access a primary care physician, can't get a doctor's office for 4 or 5 months, a doctor's appointment for 4 or 5 months, irrespective of what they were willing to pay for it. So as a result, the bulk of the community has gone concierge. The concierge is an abnormality, but the fact that even if you've
But 70% of the population in Greenwich is middle class or below. It's actually got a pretty substantial Medicaid population.
it does, but John, what is fascinating is even with the money, the folks who do have it, they can't get an appointment. So we are now deployed in everywhere from rural America to employers like uh, the state health plan of Georgia. We have it in the state capitol building. We put it in a year ago. They've just signed up for their second care station to be deployed across. They want to have a network of care stations across Atlanta for their state employees. We are deployed in partnership with United. We're deployed inside of everything from a prison to outside of Fiesta Marts in Texas. We are in a homeless shelter.
So I think
It's
we've we've
fascinating.
we've touched we've touched that a little bit. Before we wrap, Karthik, I'd love to have you talk a little bit about why you think this particular part of your career, this particular company, ties together your capabilities, your ambition, and soul.
There are too many people, millions and millions of people, who are making fundamental decisions around fundamental choices. Do I pay my rent this month? Do I get health care? Do I go see a doctor? Do I buy my groceries this week, or do I refill my prescription? A lot of these people need a break. That one break could possibly change the rest of the quality of their life just on other fronts. And if we can be that break, we will have done our part. For someone who has been passionate about access for the longest time, this is what we're doing is the perfect hybrid of the way we've traditionally looked at care and what telemedicine brings to the table. And the last thing I would leave with that is we have an access infrastructure challenge as a country. So when I think about OnMed and I think about the opportunity we have, and I think about, and I take a step back and I look at what is important to us as a country, I would expect the care station to be fundamental to our public health infrastructure as a country. A care station as a node across millions of nodes in this country, where every single node becomes either it is your medical home or it's your primary point of care, where you then get routed to wherever you need to get to next. But we need to rethink the way we think about our health infrastructure. If
Well, that's absolutely true, Karthik. We both have suffered from that.
We have, and what I would leave you with, John, is, and I would leave your listeners with, is if 120 million Americans did not have access to water, we would be up in arms. If 120 million Americans had suboptimal access to power, or power that was in and out, we would think our government is letting us down. We have 120 million people who have suboptimal access to healthcare. We should be kicking and screaming a whole lot louder than we are right now.
I think we both agree on that, and that government on its own, let alone the private sector, could be doing a lot better.
A lot more.
Well, that's it for Care Talk. If you liked what you heard or you didn't, we'd love you to subscribe on your favorite service. And Karthik, you've laid out a really exciting vision. Thanks for sharing it with us. And also the congratulations on all your success across multiple fronts.
Thank you.
There's obviously a lot more demand than there is supply. So I expect we'll have you back at some point to talk about that.
Thanks
for joining.
Of course.